Good evening to all, and I am happy to introduce this seminar about endometriosis and adolescents, and it's a great honor to have a very special speaker, Professor Ertan Saridogan from the University of London. He is a very expert of endometriosis. Since many years he studied this disease. He's an expert surgeon and also an expert in reproductive medicine. Therefore, I think it is really the best person that can speak about adolescents and this endometriosis disease. Thank you, Ertan, and I appreciate a lot your work and your experience.
Caterina, thank you very much for this kind introduction. I'm humbled with your kind words. So this evening, I'm going to try to cover knowns and perhaps unknowns about adolescent endometriosis. So endometriosis is quite often described as an enigmatic disorder, and adolescent endometriosis is no exception. And in fact, if anything, there are probably more unknowns about endometriosis in adolescents. So there are lots of questions about adolescent endometriosis. What is the true prevalence? We probably don't know, but I'll try to shed some light on it. And some people claim that endometriosis in adolescents are only in early forms, superficial forms. Is this true? And some claim adolescent endometriosis is a progressive disease, so that it has to be acted upon at an earlier stage. So just as it goes in English language, you need to nip in the bud, that they say. Is this true? Should surgery be performed to avoid progression? And the others say that adolescent endometriosis actually can potentially resolve on its own, or more likely to resolve on its own, and perhaps one needs to sit tight and wait. And they also say perhaps surgery should be avoided as much as possible. And is that really true? So we will try to cover that. And obviously, a common question that we face is the place of empirical treatment. We use this quite often in clinical practice for patients with pain symptoms when we assume that they might have endometriosis. So is this beneficial, or is it potentially harmful in the long term by masking the symptoms and allowing progression of the disease? So there are many unknowns, or there are many questions in endometriosis in general, but specifically about adolescent endometriosis. So what we know clearly that adolescents with endometriosis are the ones who will endure the consequences of disease much longer than anyone else compared to adult women, because they have many years, decades ahead of them before they become menopausal. So it is very clear that is what we know. And the other thing that we need to say, let's face it, as gynecologists, perhaps we are not the most confident physicians dealing with teenage girls. And some of us feel nervous about it, and perhaps this may actually have an impact on the quality of service care that we provide to them. There are a number of myths about endometriosis, as I mentioned earlier, and perhaps this starts with even before diagnosis of endometriosis. Dysmenorrhea, painful periods in teenagers, is considered as normal, and people say that that is primary dysmenorrhea, that it will go away after a girl reaches her late teens or early 20s, so do nothing about it. And then some people again claim that teenage endometriosis, even if it happens, it is always mild, minimal. Hence, there is a good chance that this is likely to resolve. And some believe teenage endometriosis actually is very rare. So this is a kind of no condition, so that they wouldn't necessarily be prepared to investigate it, arrange tests for it, or arrange an operation when it might be needed. So, but let's start with prevalence. So this is an interesting paper from our friend Peter Opel's group. They actually looked at age patterns in over 40,000 women who were admitted to hospital in Austria to have surgery. And they looked at the ones who had diagnosis of endometriosis. So you can see, so this teenage group, 10 to 15 and 15 to 20 groups, there are relatively few girls. So in 10 to 15, there were only 22, and 15 to 20 age group, there were just over 800 patients within that 40,000, 42,000 patients. And if you look at the overall proportion, only 0.05% of the endometriosis women who had surgery or who had admission with a diagnosis of endometriosis were between ages 10 to 15, and only 1.9 were between ages of 15 to 20. So it suggests that either endometriosis is rare in this group, or these girls at this age, they are less likely to be offered surgery. So let's look at the symptom, dominant cardinal symptom of endometriosis, particularly in adolescents, dysmenorrhea, painful periods. So how common is it? Well, it is common, very common. Almost 95% of women, or up to 95% of girls, adolescents, may have dysmenorrhea in published literature. And it is reported in very severe forms between 10 to 25%. And this is another report from Australia, from Neil Johnson and Deborah Bush's group. They actually, again, looked at prevalence of endometriosis in school-age girls. And they found that over 60% of the girls had dysmenorrhea, and 13% of them had severe symptoms. And 27% had some absenteeism from school, that they were not able to go to school sometime or on a regular basis. And the other thing that they found, that when schools provided education about menstrual disorders, that girls were more likely to be aware of possibility of endometriosis. So they asked about endometriosis awareness. So in these two states, in Australia, Canterbury and Marlborough, they did provide a program called ME, menstrual education, I suppose it stands for. And in these two places, they didn't offer that program. So you can see that endometriosis awareness was significantly higher where the education was provided. So perhaps there is an issue about awareness of endometriosis amongst the teenagers themselves in the first place. But that is not limited to them, because probably amongst medical profession or nurses, we still have the same problem as well. So what is the prevalence of endometriosis in this group when they have dysmenorrhea? There are two reviews about this subject. One is relatively new. It was published by my colleagues from our hospital, from the United Kingdom. It extended the publication from Thomas de Hoog's group, published in 2013. So in that review, there were 15 studies published about adolescent endometriosis, including just over 800 girls. This one extended the numbers to 19 studies, but overall figures didn't change. So I'm going to provide the figures from this earlier study from 2013. So they found that endometriosis was present in any adolescent undergoing laparoscopy in 62% for any reason. If the laparoscopy was because the adolescent had chronic pelvic pain resistant to medical treatment, the prevalence was 75%. If it was dysmenorrhea, it was 70%. And if it was chronic pelvic pain, not necessarily resistant to medical treatment, it was about 50%. So depending on the study's description of the patient population, obviously these items come up. So you might question why there are all these subgroups. But the main message here, I suppose, is that if an adolescent girl has dysmenorrhea severe enough to warrant laparoscopy, likelihood of finding endometriosis is very high, especially if they have tried medical treatment and didn't benefit from that. It is in the region of about 70–75%. Risk factors. So early menarche, family history, we know that these are risk factors for endometriosis in general, in adult women as well. But Müllerian anomalies probably form a special group in adolescents because they may be more likely to come to our attention in teenage years, as soon after they start menstruation. So if you look at the studies, which actually present case series from different countries, that we can get some idea about frequency of background Müllerian anomalies. But we need to be careful about this because it is very much dependent on where the study is coming from. And if the study is coming from a hospital where they especially look after young girls with Müllerian anomalies, then you're more likely to find higher proportion of Müllerian anomalies in adolescent teenagers. So this is about 25%, okay. Perhaps it's slightly exaggerated, but this one is over 50%. Again, this is from China. And this paper actually was critiqued recently in the EEL newsletter. And that's a typical example that this hospital was specialized in looking after Müllerian anomalies. And naturally, as a result, more than 50% of the adolescents with endometriosis were found to have some kind of obstructive Müllerian anomaly. So continuing with myths about endometriosis, as we mentioned, that endometriosis is always early in adolescence, and severe endometriosis is rare. So does the literature support this? So if we look at published data, so this is the 2013 review from Thomas Dohongo's group. They actually, within that 800 teenagers, they found 32%, almost 1 in 3 had advanced endometriosis, stage 3 or stage 4 endometriosis. And if you go further, this is one of the studies that I showed earlier. 88% actually had stage 3 and stage 4 endometriosis. And majority of them actually had endometriomas. And that probably indicates that the patient population that they put through laparoscopy or surgical treatment are diagnosed via ultrasound when you can actually detect endometriomas easily. So you end up with a patient population where most of them have endometriomas, so that they have stage 3 or stage 4 disease. So this is probably the good representation of overall adolescent endometriosis. But yes, this is a typical example. It can be severe. Another publication, so this one, in about half of the adolescent population, endometriosis was stage 3 or 4. So these are indicating that endometriosis in adolescent is not necessarily superficial or early, stage 1 or stage 2. Yet another example from Italy, and their stage 3 or 4 proportion was 68%. This is a good publication from Alain Audebert and Arnaud Mathieu's group. I think they combined their data. They were amongst 55 adolescents. 40% had stage 4 endometriosis. And interestingly, probably one of the first ones in the literature to indicate presence of deep endometriosis in adolescent endometriosis was this group, that more than 10% were found to have deep endometriosis. This is our earlier publication from 2006. And we did laparoscopy to 35 teenagers resistant to medical treatment, and we found about 35% of them had endometriosis, and more than half, well, it's small numbers, but 5 were mild to moderate and 6 were severe endometriosis cases. And amongst the severe endometriosis, we had 2 rectovaginal nodules, 1 rectovaginal combined with uterovesical nodule, 1 rectosigmoid nodule, and 1 ureteric endometriosis. And in fact, it had caused loss of kidney function on one side. So these are possible. Hence, we should not assume that endometriosis is only few spots here and there in adolescents. So, coming back to the next item, endometriosis progression. So some groups feel that endometriosis is a hidden, progressive, and severe disease that deserves attention. So not just compassion. And I suppose we can agree with the concept here. Yes, it does deserve attention and not necessarily just compassion. But is it a progressive disease? It is not well established. So if we look at this data, actually it supports their concept. This is the French data that I mentioned earlier, 55 adolescents. They actually did, this is the longest follow-up data published. Mean follow-up was 97 months, so 8 years, but they had patients who were followed almost 20 years within this group. They had follow-up data of the 50 adolescents. 17 of them actually had a second look laparoscopy. 2 of them had marked increase in severity. 5 of them developed new endometriomas, and 7 of them had recurrence of their endometriomas, which were detected in the first laparoscopy. And 9 of them developed new deep endometriosis, whilst 3 of them had recurrent deep endometriosis. So these were confirmed at laparoscopy. So this does support the concept that it, at least in a proportion of teenagers, it is a progressive disease. But the editor of Human Reproduction at the time, Hans Evers, didn't agree with this, and in the same issue where that paper was published, he wrote this editorial. He said, is adolescent endometriosis a progressive disease that needs to be diagnosed and treated? So he was really questioning this concept. And he said, let's look at prospective studies where people or patients, this is not necessarily adolescent endometriosis, but endometriosis in general, have a second look laparoscopy as part of a trial, a study. And if you look at these studies, small numbers, 140 in total, but the progression was seen only in 29%. And it was either stable in the remaining 29% and regressed in 42% in these studies. So jury is still out. I suppose we have to recognize that endometriosis in itself is a progressive disease because it doesn't start overnight. You know, it must start at some stage and then gradually progress. But is it a different scenario in adolescent is unknown. The other important message that we need to give, I suppose, today is the women who eventually become diagnosed with deep endometriosis in the future, or endometriosis in general, find the beginning of their symptoms in their teenage years. So this is data from Mary Lou Bolweg founder of Endometriosis Association in the USA. So you can see that a big majority, 38% or 28% of women who were diagnosed with endometriosis in later life found that their symptoms started in teenage years. And this was published, this was supported by another publication from Charles Chaperon's group in Paris. They actually looked at, I think, around 250 women who were diagnosed with deep endometriosis and explored their history. And if you look at, you don't need to worry about upper part of the table, but if you look at this lower part of the table, absenteeism from the school during menstruation was a lot more common in women with endometriosis, and use of prescription combined oral contraceptive pills again was more common in women who eventually were diagnosed with endometriosis, deep endometriosis. So that does indicate that perhaps the problem really started in adolescent years, based on these two publications that I just showed. Again, this is further support from Chaperon's group. You can see that prescription oral contraceptive pill because of severe dysmenorrhea was significantly higher in girls who had deep endometriosis. So, how do we diagnose? Diagnosis, obviously, we follow our learning from medical school. We take a history from the adolescents or their parents. We examine as much as we can. Examining adolescents can be challenging or may not be possible, especially when they have not been sexually active. And we use our imaging before we embark on laparoscopy. So what are the symptoms? It's very similar to symptoms that we see in adult women, but one claim that is made in some publications is that pain symptom in adolescent may be more non-cyclical compared to adult women, where the cardinal symptom tends to be dysmenorrhea. I'm not quite sure this is definitely a consensus in all publications, but this is a point made in some publications. So here that brings me to our Moderator's very important publication published in Fertility recently. So this is I would say a landmark publication that I think all of us should read and look into details. They actually looked at 270 adolescents or teenagers who had ultrasound scans, but specifically transvaginal and transrectal ultrasound scans. They excluded some girls who had transabdominal scans. And the indications for the scan are written here. Some had irregular periods, some had dysmenorrhea, some had heavy menstrual bleeding, some were referred for congenital anomalies, some had diagnosis of ovarian cyst, and some were there for a checkup. And that was about 1 in 4 girls. And when they looked at this group, they identified a significant proportion of them had symptoms that may suggest endometriosis, such as dysmenorrhea in more than 50%. Dysmenorrhea was obviously relatively uncommon because many of them are not sexually active yet. Interestingly, heavy menstrual bleeding is a regular symptom. And in fact, this is in contrast to studies that measured blood loss objectively in women with endometriosis and did not find differences compared to women without endometriosis. But this comes up regularly. Women with endometriosis may complain of heavy menstrual bleeding. So, in this group, they found out of 27 teenagers, 36 had endometriosis, or findings that suggest that they have endometriosis. What were these findings? They had either negative posterior sliding sign, they had signs suggestive of adnexal adhesions, though they had visible deep endometriosis lesions on uterosexual ligament, rectosigmoid bowel, or bladder, or they had visible adenomyosis in teenage years. So, and that was about 1 in 20 had adenomyosis. And endometriomas were seen in about 8% of 270 teenagers. But endometriomas were obviously the most common finding amongst all these findings suggestive of endometriosis. And now, here, if we look at the group who had ultrasound finding of endometriosis, you can see that presence of those symptoms that we looked at earlier, they were more common in this particular group. 86% of the teenagers who were diagnosed with endometriosis had dysmenorrhea, or 1 in 5 had dyspareunia, or more than 50% had heavy menstrual bleeding. So you can see that when these symptoms are present, likelihood of endometriosis increases. So, how do we treat it? We diagnose endometriosis on the basis of history or examination, or perhaps imaging, most comfortably ultrasound scan, as you've just seen in the example. Obviously, do we do laparoscopy in all these patients, or do we start off with medical treatment? Obviously, this is a debate that is ongoing, and there is no final or clear answer. So when we are facing adolescents who have findings or symptoms suggestive of endometriosis, or findings, ultrasound imaging findings suggestive of endometriosis, then perhaps we need to offer them analgesics, and that may be sufficient on its own, especially if they are not willing to use hormonal treatment, or they try that and they don't like it. It's not that unusual. But if their symptoms improve, quite often they do comply with it, and they can use either combined or progesterone-only contraceptives, which may be beneficial in this situation. We need to be careful about Depo-Provera in adolescents, because in the long term, we know that if it causes amenorrhea, that can cause a reduction in low bone mineral density. And when adolescents are still developing their bone density, perhaps it may not be the best option. And there's relatively little information about levonorgestrel IUS. Obviously, if they have not been sexually active, it is almost impossible to insert. But if we are operating on adolescents, perhaps later age adolescents, levonorgestrel IUS may actually be a good option at the end of laparoscopy if we detect endometriosis. It is a good opportunity to insert an NG-IUS. Again, GnRH analogs, particularly popular in North America, because of concern on bone mineral density, perhaps are less frequently used on this side of Atlantic. Surgery that you've seen examples of case series that sometimes we do surgery, especially if they do not respond to medical treatment. And sometimes, yes, you do deal with severe endometriosis. Confirm that surgery. So I'll give you a few examples of surgical case series. This is from our colleague Sina Nezat's group. They actually looked at data from, I think, around 80 adolescents, 80 teenagers. They did, I beg your pardon, it was about 20 teenagers. So they did use either excision or ablation treatment, and they used post-operative medical treatment in a significant proportion, apart from 3. And at 1 year follow-up, they found that pain was successfully resolved in 64% and improved in 16%. So overall, 80% had improvement or resolution of their symptoms. About 20% had continuing or recurrent pain. So that does indicate it works at least in the first 1 year for the pain symptoms in 80%, 4 out of 5. So this group published their data. This is from, again, Atlanta. Sina Nezat's group is from Atlanta as well. So perhaps Americans who are experts in adolescent endometriosis, like living in Atlanta. So they published their own data as well. And they actually questioned whether post-operative medical treatment was helpful. They did say that if you treat endometriosis with excision, a significant proportion would improve. This is various symptoms before and after surgery. Blue is before and red is after. And here you're looking at dysmenorrhea before and afterwards. And then the second one, sorry, this is pelvic pain, this is dysmenorrhea. And they did second look laparoscopy for some of them, and they didn't find any recurrent endometriosis in any of them. And they concluded that those who used medical treatment did not actually have a different outcome. The outcomes were very similar, whether they used medical treatment or not. So this group is against post-operative concept of medical treatment. So this is from another group from the USA. I'm sure you're all familiar with Mark Laufer and John Einerson. Obviously, John does a lot of extensive excision endometriosis surgery. Mark Laufer is more of conservative approach surgery, more of ablative treatment followed by medical treatment. And they've actually published a case recently, actually when I say recently, it was last year, in a journal of pediatric and adolescent gynecology. This is an example of a young girl who had 2 previous laparoscopies. I think she presents again with recurrent pain, so goes to an excisional laparoscopist who does this excision treatment. You can see that areas of peritoneum have been excised. Presumably that's where endometriosis was, but her pain symptoms continued after this excisional surgery. So she came back to Mark Laufer and John Einerson, and they did another laparoscopy. That is the 4th laparoscopy. Then they found these adhesions. They admitted they look like flimsy adhesions, nothing major, but they did treat them, and they put the girl on medical treatment, and the symptoms resolved. So based on the lesson from, or the message, take-home message from their case report, they claim is that excisional surgery perhaps should not be performed in adolescents because it can cause problems like adhesions, as seen in this example. So this is from our data published in 2006. We had up to about 2-year follow-up that I mentioned earlier, 11 endometriosis girls. And again, similar to the Sina Nezat's data, majority of them, 5 out of 6 with severe endometriosis and 3 out of 5 with mild moderate endometriosis, they did have significant improvement following surgery. Admittedly, we also use medical treatment following surgery, either the oral hormonal contraceptives or Mirena. And this is the other excision study from France, those 55 teenagers with up to 20-year follow-up. And you can see when you follow them up in the long term that complete resolution is in a very small proportion, only about 26%. Many of them had persistent pain and had MRI for persistent pain. There was no visible endometriosis in 12. 8 had adenomyosis. So perhaps this is something that we need to be aware of. Caterina's publication also indicates that adenomyosis is not insignificant in this group, and we need to look into that. And out of 55, 17 did have second look laparoscopy, and as I mentioned earlier, 12 were found to have deep endometriosis, 9 new, 3 recurrent, and 12 had endometriomas, 5 new and 7 recurrent. So disappointing results in the long term. Although short-term data, as seen in other publications, indicate significant improvement, perhaps that is not maintained in the long term. What about fertility? What happens to these teenagers when they come to an age when they are ready to start a family? There isn't much data, admittedly. There are 2 publications. One is this one, Ventolini publication. I think they looked at about 28 teenagers, and not all of them wanted to become pregnant, but so 4, 11, 15, 28 actually, 28, and then these are the stages. And when they started trying for a pregnancy, 3 out of 4 from stage 1, 75% conceived. 6 out of 11 from stage 2 conceived. 3 out of 12, 25% from stage 2 conceived, and none from stage 4, where there was only 1 girl. But some of these had spontaneous miscarriages, so the rates that you're seeing in the chart is slightly lower than the figures that we're seeing. So, in a way that, and then this treatment, this group didn't treat them surgically. They were treated with hormonal contraceptives in the long term. So perhaps the take-home message from this publication that majority of them do get pregnant, especially those who have early stage endometriosis, stage 1 and stage 2. And if you look at the French data, they actually, out of that, those 55 teenagers, 18 started trying for a family at some stage and during that follow-up period, and 13 conceived successfully. And majority of them, again, were in stage 1 and stage 2, supporting the conclusion of the previous paper that I mentioned. So these groups, they do not mention whether these teenagers actually conceived spontaneously or whether they received treatment, so that remains unknown. So the other question that I mentioned at the beginning of my talk, if we diagnose endometriosis early, do we end up doing less extractive surgery? So is diagnosing endometriosis and performing surgery is better than sitting tight and waiting as much as possible and then doing surgery only if we have to? And the answer to that is we don't know. We need long-term data. And obviously different people will make their, will have their opinions, they make comments, and they, promote their approach to management of adolescent endometriosis, but it will not be based on good quality data. But one thing we need to remember, that endometriosis in the long term, if you leave it untreated and leave the teenager or the woman continuing to suffer with chronic pain, the pain will become centralized. So centralization of pain is an important concept in endometriosis. And in this situation, if you later treat the endometriosis effectively, then pain may not disappear. The person turns into a person with chronic pain, despite elimination of the original condition which caused pain. We need to be mindful of that. So we need to remain on top of the pain. I'm not saying that we have to operate on everyone, but we need to offer them a treatment that will control their pain. So to conclude, we can say that yes, we have some evidence that endometriosis has its roots in adolescence, particularly deep endometriosis. And endometriosis in adolescence is not necessarily early endometriosis. A significant proportion, perhaps somewhere between 25 to 60% have more advanced endometriosis, including deep endometriosis. And we should not assume that surgery is unnecessary in teenagers, in adolescents, either to diagnose endometriosis or treat it. And published evidence, those studies that I showed earlier with surgical outcomes, they do resemble the studies that we see in adult women, you know, that there is relatively short-term data, outcome data. With Attila Bokor earlier, we were discussing about follow-up data, and you know, in adult women, the longest data that we have is about 3 years, so it's not long-term data, but they do indicate that surgery is beneficial, at least in the short or medium term. What type of surgery we should perform, whether it should be excision or ablation, we don't know. Yes, some groups suggest that it should be conservative, ablative type treatment, but the others believe it should be excisional. But what we need is research in this field. It is crucial in determining best long-term outcomes, so that we can determine what is the best way to diagnose and treat endometriosis in this patient group who are likely to suffer for many, many years, for decades in their lives with this condition. Thank you very much for your attention.
Thank you very much. This was a wonderful, exhausting lecture, and I appreciate it a lot. Actually, we have not a question on our chat, so I can do my first question. And the first is, obviously, I am interested in the treatment, and so just to be practical. If you have a suspicion of endometriosis, or you see an endometrioma in adolescent girl, you suggest a contraceptive pill in continuously or cyclic. That means, because it's very difficult to give them a contraceptive pill, and it's much more difficult to give them continuously. So how is your first approach?
If obviously we use progesterone on the pill, it is continuous. You know, particularly for teenagers or women who do not tolerate the combined pill, we use desogestrel progesterone on the pill, which does cause amenorrhea in about 1 in 4. It works better. So that's obviously, that's not your question anyway, but it's continuous. But the important question that you're asking, whether we should use cyclically or continuously. So in our approach, this is obviously, again, our approach, not necessarily evidence-based, but we usually start cyclical. And after the first 3 to 6 months, if their cycle pattern settles, they do not have much breakthrough bleeding, we offer them the option of taking it continuously, especially if they continue to have pains with periods. Because if you can avoid periods by using the pill continuously, then that would be a huge improvement by avoiding period pains. and due to continuous taking of the combined pill. There is this concept of extended use of the hormonal contraceptives that you might be familiar with. WHO actually promotes this a lot. So what they suggest that pill doesn't necessarily need to be taken, 3 weeks on, 1 week off. You can actually take it continuously until there is breakthrough bleeding. At that point, you stop it and have a break for 7 days and then restart it. And that seems to avoid the trouble of breakthrough bleeding in the majority. But if the girl does not mind having a little bit of spotting here and there or breakthrough bleeding, again, you don't necessarily need to stop. We encourage them to continue using it without breaks. So it's a good strategy to use and avoid periods. Is it better in the long term for avoiding de novo lesions? It's obviously a theoretical possibility because you will prevent new arrivals if you prevent menstruation, so there won't be retrograde menstruation. It might be, there might be an additional benefit there, but we don't have evidence that that is the case.
Do you think that we should have a different approach if we have a different type of endometriosis? That means if we see it only endometrioma or if we see deep endometriosis. This is for surgery and also for medical therapy, because only endometrioma, there is a problem on the ovarian reserve, also if they're very young. Only a small deep endometriosis on the uterosacral ligament, which we often see now, are another type of treatment, because then probably surgery can be a good thing.
Yeah, I think going back to what I said in the concluding slide, we do need data. Is it better to avoid surgery and do our best to give them medical treatment, or perhaps we should do surgery and put them on medical therapy postoperatively to reduce the risk of recurrence? So in this situation, I don't actually have a fixed strategy. Quite often I start with medical treatment, whether it's deep endometriosis or endometrioma. With larger endometriomas, I tend to accept that we are unlikely to avoid surgery in the long term, and perhaps we accept that we need to do the first surgery and use medical treatment. But when they do not respond to medical treatment, then I do not hesitate to operate on teenagers. As I said earlier, we need to remain on top of the pain. Otherwise, we turn them into chronic pelvic pain patients, and they are, it becomes a lot more difficult to manage.
We have some questions. One is from Jörg Keckstein, and his question is about what about if you consider the negative sliding sign also an effect or something that gives you the markers of endometriosis?
Maybe you're better placed in responding, Caterina.
I think that we can use it as markers. Then there's another question, and what do you think about anogenital distance in the diagnosis of endometriosis? Do you care measuring in the adolescents?
Well, I think there is probably 1 or 2 publications on this. No, we don't in our practice. I don't think it's a very reliable approach to diagnose endometriosis. I
have another comment on the surgery. So most of the paper that you nicely present give us a stage in ISRM classification, which we know doesn't see or doesn't consider deep endometriosis. And on the other hand, we go to surgery only showing in these young teenagers not going in the retroperitoneum. That means most often they go and see some peritoneal endometriosis and they don't go deep. And I often have some I think that it can be some endometriosis also more than they can see by laparoscopy.
Yeah.
So I think that these papers has to be not considered too much.
No, I completely agree. And in fact, as I mentioned, that there aren't that many studies that comment on deep endometriosis in adolescents. Actually, there are two. One is our paper. I can see my colleague Andreas Stavridis, who is now in Cyprus, is one of the audience. He actually gathered that data, and that was one of the first publications actually indicating presence of deep endometriosis in adolescents. Before that, it was a no entity because no one actually commented on deep endometriosis. And then more recently, the French data, the 55 patient case series, again, that does show how important deep endometriosis is in the adolescent group. That was not that recognized in earlier studies. And majority of the studies that depend on report surgery, they don't actually comment much on deep endometriosis. Some of them specifically concentrate on endometriomas, and that's probably because they can easily detect endometriomas on transabdominal ultrasound examination.
Yes, but also if they go to surgery and they have pain, they only look to laparoscopy and not go to see the deep endometriosis, and which is, I think, one of the concepts that if you go and give contraceptive pill in cyclic, and this is the study of Chaperon that said that he found the deep endometriosis all in this group. Probably there was deep endometriosis since the teenager time, and they don't recognize this. And this is, I think, a very important data that we have to admit, that we have to look for. And not only with ultrasound, but also with their history, and also with I think the digital visit of these patients, because we need also this in this young patient. I have another question. Do you ever see adolescent patients with child abuse? Oh, mama. Since this was also correlated with endo patients in some papers, do you think that endo group of adolescents could belong to such special problems?
Well, I'm aware that there is, I think there are some publications about possible association, but I find it difficult to actually explain, come up with a plausible connection. So there might be an indirect association, not necessarily a causal association there.
Mm-hmm.
There's a question from Professor Kechstein that we missed. He's asking if there's any data to avoid surgery by performing frequent ultrasound, even when we see some pathology in the transvaginal ultrasound without severe symptoms.
Do we have data? No, we don't have data, unfortunately, on this. Caterina?
No, I have no data. I have really, it is, we know that we try not to go to surgery. So it's we avoid surgery, we try to go to medical therapy, but obviously there are surgical cases, and therefore we have to admit that if the endometriosis had large endometriomas or a lot of pain, we cannot avoid the surgery. So I think that the imaging can help to reduce surgery, but this we know, not only in adolescents but also in adult. We go less to surgery when we have an endometrioma. Now we go more with medical therapy.
I think yes. Sorry.
We have another.
Whilst you're on that, Caterina, so I think the message is important. Jörg's question is important, and what you said is important. That especially for deep endometriosis and endometriomas, that laparoscopy should not be the diagnostic method anymore. It is a method to treat it. And even for superficial endometriosis, signs like sliding sign, they are possible to use and detect even superficial endometriosis. And we need to be now talking about discussing these. That should be the norm standard, not using laparoscopy for diagnosis.
There's another question. At which point you are worried about ovarian reserve and future fertility among adolescent patients?
Okay, so I think the patients who I become worried are the ones who develop recurrent endometriomas after surgical treatment. If they have recurrent endometriomas, especially bilateral endometriomas, if it was bilateral in the first place and they develop bilateral endometrioma recurrence, then you probably have a problem. And in those situations, you need to be careful about how to handle the situation. So as I said, I don't usually mind doing the first surgery in adolescents, and I expect that majority of these will have good fertility as long as they don't delay pregnancy till in their late 30s or 40s. Whilst they have good level of fertility, ovarian reserve in younger ages, like in their 20s or early 30s. But the recurrence patients are challenging for us, and also those women who are not in a position to start family in a reasonable age. If they are beyond age 37, 38, then we do have a problem again.
There's another question, very interesting. Can you please comment the use of Diagnostic in adolescents, especially regarding concerns about bone density?
So actually in the UK we don't have, or we didn't have Diagnostic until very recently, so we have no experience whatsoever.
We gave Diagnostic in Italy since many years, and I give them often if there are endometriomas, where Diagnostic works a lot good because they really shrinks, but not more than 6 months, because I worried about bone density in a young girl. So it's better to give them estrogen and progesterone pill, contraceptive pill, continuously. Then you have also the estrogen, and it's better.
Yes, so this is as I mentioned earlier with depo-medroxyprogesterone acetate, that long-term use of progestins is associated with hypoestrogenism when they remain amenorrheic for 5 years or longer. And Diagnostic is a progestin.
Yes.
And for this reason, I think the overall opinion is not to use it for prolonged periods.
I agree. So I think that we have no more questions, and I thank you so much for this interesting lecture, and I hope that everyone enjoy and learn also something, because I learned also something, and it's very interesting to have it. So thank you.
Then perhaps I should finish by thanking the EEL for giving me the opportunity to present this, and thank you for moderating, and thank my longtime friend, Professor Engin Oral, whom I've known for the last, I suppose, 3-4 decades now, for inviting me to give this lecture.
Thank you to all. Bye-bye.
I think Professor Oral wants to say something. I will unmute him.
Yes, please.
Okay.
Caterina and Ertan, thank you so much for this very informative lecture. Let me say something about before closing. And on behalf of the EEL board members, and Happy New Year and Merry Christmas. We need more fresh air for the next year, I hope. And the other things, as you know, we will continue our webinar series to next year. The next one at January, 19th of January, our guest speaker will be Dr. Kekstein. He will speak about his famous topic, classification of endometriosis, what we are now. And we will continue our webinar during the next year. Another things that we are doing, EEL Masterclass project. We have 6 different cities in 6 different masterclass symposium in 2 days. You can get the details from our websites. And the last thing I have to remind you, we have the regular annual EEL Congress, and next year in December, it will be in France and by President of the Horace Roman. Thank you so much for tonight.
Thank you.
Thank
Thank you,
you.
Caterina.
Thank you.
Thank you.
Goodbye.
Bye-bye.